it's just a huge honor for me today to be podcast interviewing Dr. Olya Zahrebelny. She graduated from the Faculty of Dentistry at the University of Toronto, Canada, then completed a General Practice Residency focusing on oral surgery, oral medicine, and oral pathology. She has practiced in both hospital and private practice environments for the past 39 years, which means she graduated from dental school when she was 2. Dr. Z, as she is fondly called by her patients, is a former consultant to commercial and government insurance programs. She has also taught at 3 dental schools in the departments of restorative dentistry and oral medicine diagnosis, as well as holding the position of attending physician at Swedish Covenant Hospital for 19 years, and also as an attending physician in the General Practice Residency program at the University of Illinois Chicago Medical Center. Selected for 4 years in a row by Dentistry Today as one of the leaders in continuing dental education, and for each of the last 18 years as a leader in dental consulting. She is featured on their website and is in the December 2016 issue of the magazine. She has lectured extensively throughout the U.S. and abroad at all the major dental meetings, including the ADA, Hinman, Chicago, Midwinter, California, Dental Association, Academy, Osseointegration, AAP, AAOMS, as well as for state and local societies and study clubs, continuing education programs, and hospital general practice and oral surgery residents. She is a former guest columnist for Inclusive Magazine, Dental Economics, Dental Equipment Materials, Insurance Solutions. Her book, Assessing Medical Benefits and the Comprehensive and Surgical Dental Practice, has now been in print for 18 years with yearly versions, edits, and updates. Dr. Z is a comprehensive general dentist with special interest in cosmetic and implant dentistry and a principal in the Z Group, a practice management consulting company. My God, your bio is like should be in the Guinness Book of World Records. How are you doing today?
I'm doing very well. I just got back from Europe. I'm a little jet lagged, so bear with me here.
So where were you in Europe?
I was in London for a week, right after the bombing there, and then I was there during the elections, and after that I was in Spain for a week.
I'll tell you what, I love Spain, Barcelona, on the Mediterranean. If you're on the Mediterranean, it doesn't matter what it touches. It could be Portugal, Spain, France, Greece, Albania. It's just, God, that Mediterranean is a fun place to hang out, isn't it?
Absolutely, absolutely a fun place, and I was there during Gay Pride Month, and I was staying with at an Airbnb with a gay gentleman, and we had a blast.
Wow, that's so Airbnb. That's you're the first person I've ever met that did that work out well?
It's a great experience. I did Europe last year for 2 weeks in Germany, Austria, and Italy, and stayed in Airbnbs during that visit, and Airbnb in London and in Barcelona. Excellent experience.
Wow.
I can't say enough great things about it.
That is funny how Airbnb and has turned the hotel industry upside down. And my favorite economist was Joseph Schumpeter in his book Creative Destructionism. And he said, if you don't destroy the horse and buggy business, you can't have the Model T Ford. And so many governments in the old world protect all the old industry. So you have to destroy the old to create the new. And people don't realize that that's the ugly side of the truth of growth is creative destructionism. And Uber, I can't believe when I was in New York, I go to the airport, I have to wait like 45 minutes because they banned Uber from the airport. Like they're going to save the old taxi driver. I mean, why don't they go save horses and goats and horse and buggies? I mean, it's just crazy.
I use Uber all the time. I use it wherever I travel. I used it in throughout Europe. In Spain, Uber is banned, but everywhere else, Uber is allowed in Europe. So I've been only using Uber and staying at Airbnbs, and it's been an awesome experience.
And whenever a country tries to protect the old world, like Spain, banning Uber, that just means that the country's going to go nowhere. It reminds me of, the historic society. I always call them the hysterical society, because if they had it their way, everything would still be a cow town with a saloon. They want to preserve everything. But notice they never want to preserve it with their own money. They want to go to the government and pass a law that bans them from tearing it down. They can't find individuals to part with their cash, so they just go to the government and steal my cash to protect their wooden barns and their grain silos. So, what are you most passionate about, and why are you why did you get into insurance billing, dental insurance? What Why is that a passion of yours? Medical billing solutions for the dental office, which your website is the Z Group LLC, and the Z is for Zara-bell-knee.
Yes, it is. Yes, it is. Well, you'll notice, first of all, and this was pointed out to me a couple of years ago, and it didn't even occur to me. In the middle of the name, my last name, you see the word rebel.
Oh, nice.
Okay? And everybody says, no wonder you're doing what you're doing. You're out there on a limb. You started with the medical billing, 20 years ago, and outside the box thinker. And so many people in dentistry are so afraid of medical billing. They think it's illegal. They think they're going to get in trouble. And I'm still here. I'm not in jail. I've never been audited. No problem there. None of the clients that I work with have ever been audited. So medical billing is such a huge secret, and I think a lot of it has to do with the fact that people are under the misconception that it is only for physicians, or in the case of traumatic injury. And I think the reason for that is because it's not addressed in the dental schools. It's not addressed for the most part by organized dentistry. And I think that's a huge disservice to our patients, because so much treatment is not being done on patients that need it, but they can't afford it. And I always laugh when practice management people, you have to explain the benefit of the treatment to the patient. They have to understand the benefit, and then they'll sign up for it. Well, I understand the benefit of driving a Lamborghini. If I can't afford it, I'm not going to buy a Lamborghini. So it has nothing to do with understanding the benefit, or very little to do with it. It has everything to do with the bottom line. And what are you going to pay? Your mortgage, your rent, your food, or you're going to pay for your teeth? And that's what it boils down to. I started with the medical billing because I was exposed to it when I first moved to the US from Canada. I joined a hospital-based practice, and people are under the impression that hospital-based practice patients are only medically compromised, and that's not true. You see normal patients as well as physicians, nurses, and patients who require hospital monitoring and OR dentistry. And when I joined the practice coming from Canada, which is a single payer system medically, and my brother is a physician in Canada, so he keeps me up to date with what's going on there. But dentistry in Canada, only 20% of patients have dental insurance. So for the most part, it's a cash system. And when I moved to the US, I was exposed to medical billing because of the fact that the majority of what I was doing, the procedures that I was doing as a general dentist, were being billed to the medical insurance. And I thought, how is that possible? I'm a general dentist. I'm doing general dentistry procedures. I'm not a physician. How is this being billed to medical? And that was my first exposure to medical billing. And as I spent more time with the hospital-based practice, et cetera, we became very proficient at it. And I thought, you know what, it's time to also learn the inner workings of insurance companies, because there's so much going on behind the scenes that people kind of guess and assume, and they kind of try and work the system, but they don't really know what's going on. And so I did consulting work for insurance, and that was quite the eye-opener, in the processing and how things are approached and what's required documentation-wise, et cetera, and how medical reviewers look at our claims and our documentation that are sent to them. And most dentists, when they bill medical, are approaching it as if they're billing dental insurance, and that's completely the wrong approach. You have to think like a physician. You have to put your documentation together like a physician would, and present the material like a physician would, and then it will be processed. You have to keep in mind who your audience is, and it's a physician or a nurse that is going to be reviewing your documentation, and not a dentist.
That is very interesting. I like the saying that the first Chinese medical text, it was found 2,600 years ago, and it said, superior doctors prevent the disease, mediocre doctors treat the disease before evident, and inferior doctors treat the full-blown disease. And basically, dentists are doing the treat the full-blown disease. They're used to just billing cavity, root canal, crown, extraction, and so what is the how do they start thinking like a physician?
Well, you have to, first of all, when I speak with dentists, I'm amazed at how many of them say, I'm just a dentist. You are a physician of the mouth, and you have to conduct yourself accordingly, and patients will treat you that way. And I think a lot of the problem is the fact that the ADA is separate from the American Medical Association. I think it should be a subsidiary of the American Medical Association, and that way the population, the general population, would not perceive us as second-class citizens. That's the first issue. The second issue is dentists have to approach the patient from looking at the total picture, the whole body, and then zeroing in on the mouth, just like a physician does when examining a patient. So you have to look at the whole head and neck area, ask a lot of detailed questions about the patient's medical history, get down to the nuts and bolts, and ask a lot of detail and explain to a patient, in order to get a total true picture of your condition, we need to know what is going on behind the scenes. Not just what you think we should know, but these are other issues that we have to know about that may impact your oral and your dental condition. Because patients only give you the information that they think is relevant to what you're treating. And their perception of dentistry in general is very narrow.
I no longer believe you that you were born in Toronto because you've been talking for 10 minutes and haven't said A yet.
I lose the A. I only pick it up subconsciously when I'm back in Canada, and I haven't been there for a while. So,
my favorite movie accent is still Fargo because it's in North Dakota. Have you ever seen the movie Fargo?
I have.
And when you get that far north in Minnesota or North Dakota, they're actually sounding like they're Canadian. I know what everybody's thinking is, what is covered by medical plans? You have your Dr. Z's top 10 list. What is that?
Dr. Z's top 10 list lists all the billable procedures that are covered by medical plans, to one extent or another, starting from exams, consultations, appliances, surgical procedures, implants, bone grafts, tissue grafts, periodontal treatment, biopsies, excisions, prosthetics. I mean, when you look at the list of the procedures that are listed on the website and in my book, you can see why, as a general dentist, literally 85% of what I was doing was billable to medical insurance. And the coverage is excellent.
So where's the best way to find your book? Is it on the zgroupllc.com or on amazon.com?
It is on the zgroupllc.com website under the products heading.
Okay, I like that. I just learned recently that those three little horizontal bars, everybody's supposed to know that's the menu. I think they told all the millennials and forgot to tell all the grandpas. I did not remember getting that letter in the mail. So what products do you have, and do you recommend that the dentist actually buys this and reads this and all this, or is this something you buy for your office manager or your your admins, your dry hand admin staff?
Well, one of the things that's critical to medical billing and to the success of medical billing in an office is that the clinical end and the business end have to have a symbiotic relationship. In other words, each has to work in partnership with the other, because the biller on his or her own cannot bill medical insurance without the information coming in the right format from the clinical end. So as far as the book goes, the book answers about 98% of the questions regarding medical billing. However, I find that most people learn best visually. They learn best by asking questions. And when I do my seminars, my 1 and 2 day programs, they're very interactive. I keep them to a very small size, typically under 20 to 30 people at most, because I find that no question is stupid when you're learning. And people have a lot of questions about insurance, a lot of questions in particular about medical insurance, because it is such an unknown to them and such a mystery, and that has always been thought to be illegal, if you will, for dentists to bill medical. And that could not be farther from the truth.
Now, when you said it answers 98% of the questions, were you talking as a Canadian talking the metric system, or were you now an American speaking imperial math?
No, I've been here longer than I was in Canada, so I'm speaking as an American.
And how much is it one book that you sell, or is there multiple books?
It's
And
one book. It's one book. It's got 635 pages. It's got everything, I mean, from A to Z regarding medical billing. It's got over 200 pages of claim examples, and each example has the letter of medical necessity. It has the claim form itself. It has the codes explained. It has everything that you need to know about billing medical. It has an awful lot of detail. The book initially started as a handout. When I first started teaching medical billing about 20 years ago, it started as a 50-page handout, and it has now grown to being 5 pounds and 635 pages. Because every year I add to it as people say, can you put this in it? Can you put that in it? And I keep adding to it.
and how much money does the book cost?
The book, I think right now, the hard copy, there's a hard copy and a digital version. The millennials love the digital version. Most offices, what they do, they get the hard copy for the office, and then the digital version they can access from their laptop, their tablet, their phone, whatever, when they're not in the office. So a lot of doctors, at the end of the day, the last thing they want to do is stay in the office. So they go home, and after they've had a martini, a sangria, whatever, they sit down and they do their patient charts or documentation in the evening, and they're able to access all the information in the book from their laptop or tablet. There's also all the templates that are in the book for the letters of medical necessity, for the operative reports, for everything are also on CD, so that you're able to use that and edit it to modify it for your patient's specific situation.
And the dentist always, you can't think of the cost, the fixed cost. You got to think of the total cost over a lifetime. So you're talking about a $450 book. What percent are these companies taking that do your medical billing for you, which goes on into perpetuity? Well, what is the average?
I don't recommend that you use a medical billing company.
I know, but the ones that do, what is their cut of that?
Typically between 13 and 15%
I
of
know. So 15% of all this stuff, month after month, year after year, and they'll balk at a $450 book. They'll say, I don't know if I want to spend $450. So then they'll go spend $45,000 the next decade having someone else do it.
And that's why it's important. And I say it's actually better for you to have somebody in your office trained to do it and cross-trained with different people in the office doing the medical billing. So should you lose one person for one reason or another, others can pick up the slack. And it's well worth the investment of for that person's training with the doctor rather than paying a billing company.
And you walk the talk when it comes to cross training, because you cross train between a martini and sangria. I like that about you. You don't just do one sport.
Depends on my mood.
Depends on your mood. Yeah. So do you see this? You've been teaching this for 20 years. Is the medical billing? Would you say it's flat? Would you say it's growing? Would you say it's contracting? Where's it been from 20 years ago, 10 years ago to now?
What I found has happened is as dental insurance has become more and more pathetic in its benefits, more and more restrictive in its benefits, medical has picked up the slack. So, when you think about it, and I don't know, why this doesn't occur to people. First of all, when I started practicing, a prophy was $25, a crown was $200. And this is when I started practicing in the US, okay? You look at the premiums, you look at the calendar year maximums. The premiums have skyrocketed. Calendar year maximums have stayed the same. Benefits have diminished significantly. When I started practicing, you could do an FMX every year. You could replace fillings every 2 years, crowns every 5 years, prosthetics removable and fixed every 5 years as well. That's not the case anymore. You don't see that. So what has happened, a lot of these procedures, especially the surgical procedures, exams, appliances, whether it's for sleep apnea, night guards, TMD appliances, surgical stents, diagnostic stents, biopsies, excisions, all of that have been picked up under the medical plans. And patients don't know. They don't even know what their dental benefits are, let alone their medical benefits. And dentists don't know either. To them, it's such a huge mystery. And again, I think a lot of it has to do with the fact that it is not addressed in dental school. And well, a lot's not addressed in dental school. I mean, my education began when I left dental school, pretty much. And, when I look at the dental education model, think about how physicians are trained and how dentists are trained. Physicians are trained in real life situations, in hospitals, treating real patients under the direction of the best in the hospitals. How are dentists trained? They're trained in dental schools. Most of the patients they have are patients that can sit for 3 hours for a simple filling. When you look at the faculty in dental schools, the full-time faculty, they are either dentists who have never practiced, dentists who have failed in practice, or ex-military people, all of whom, again, their real life experience with real patients when finger dentistry in the real world is not realistic. And I found that in my experience teaching in the dental school and as a student, that students tend to go with their real life questions to the part-timers, the ones that are practicing and are teaching because they enjoy teaching. And whenever a student would say to me, how would you handle this? How should I handle this? I would say to them, well, how did the full-time person tell you to do it? And they'd say, they'd give me an answer, a textbook answer. And then they'd ask me how I would do it. And they say, but Dr. So-and-so said, do it this way. I said, tell you what, if you want to be called on Thanksgiving morning at 3:00 in the morning, that's how you do it. But if you want to have a pleasant holiday with your family, this is how you do it. That's real life. That's how you handle it.
See, I would want an emergency during a family holiday, just an excuse to get the hell out of that room. So I would, I might. I also want to say something about you have taught at a hospital residency for 19 years. A lot of kids as they're getting to be juniors, seniors, they start asking about residencies, and this sounds pretty crass and bad and rude, but the key to the best residency is to be in the biggest city. When KU has moved their hospital training from Lawrence, Kansas of 30,000 to Wichita, Kansas of 380,000. And you know what's better than 380,000? The 3.8 million metro of Phoenix. Chicago is probably what, a 5 million metro? And you need 5 million humans to get a lot of these examples of really rare stuff. And I think the best residency is the biggest city you can find. I don't care if you have to go to China to get there. You just want to be in a really, really big city.
I think, residencies now, my opinion of residencies is that they should be mandatory because that's where I got the majority of my knowledge and experience from in treating real life situations and rare situations. I trained in 3 different hospitals in Toronto and in Canada, and it was an unbelievable experience. And I compare that to my colleagues that had no residency training, and there's no comparison. And I look at the kids that are coming out of residency programs, the dentists that have been through them, night and day difference between their demeanor, their professionalism, how they handle themselves, how they handle patients, their communication skills with physicians and with patients, night and day difference. I absolutely recommend a residency to everybody. Absolutely. But yes, do pick your residency very carefully.
Yeah, just pick it on straight out demographics. I just go to the largest city you can go to, and that's where sometimes you just need 9 million people in Manhattan to see that one oral cancer on the side of the tongue. You know what I mean? And all the rare stuff. Seems like the people that I know had the best residencies were in New Orleans, Manhattan, Los Angeles, Chicago, Houston. They were never in Parsons, Kansas. At the VA.
Very true.
So when you go to the VA in some small town of 50,000, that's good. That's great, but it could be a lot better. So there's 9 specialties recognized by the ADA. Does medical billing apply to some of those specialties a lot more than others? And are some of the specialties do not even apply? Does it not work for, say, orthodontists or endodontists or?
Well, for the most part, when you look at, for instance, pediatric dentists, a lot of the situations they're treating, a lot of those children are management issues because of their medical issues, their management issues because of their age, etc. All of those situations are medically billable. endodontists that are treating patients with periapical pathology, with abscesses, facial cellulitis, etc. Any type of infection, inflammation is billable to medical insurance without a doubt. It's a covered benefit. When you look at periodontists, the surgical specialties as well, the majority of what they're doing is covered under the medical, whether it's an oral surgeon or a periodontist, anybody who is placing implants, a general dentist who's treating patients with sleep apnea, with TMJ issues, with implants, restoring implants, trauma patients. I mean, across the board, all the specialties have medically billable procedures without a doubt. Orthodontists, we tend to see them with skeletal problems, not just dental problems, something as simple as a high palatal vault, a narrow arch. You know, your approach when you're dealing with medical has to be to look at things from a medical standpoint. So for instance, if I were to describe to a dental insurance in my documentation that the problem is between 6 and 11, if I did the same thing and reported it that way to a medical insurance medical reviewer, they wouldn't know what I was talking about, because between 6 and 11 to them refers to the vertebrae. It has nothing to do with the teeth. So you have to keep in mind who your audience is who's going to be reading your documentation. Similarly, if your documentation says the problem is in the lower right quadrant, the lower right quadrant to the physician is the lower right quadrant of the body. It is not the lower right mandible. So again, they're going to say, well, why are you treating the mouth if the problem is in the lower right quadrant? Because they're not connecting one to the other, because that's their training, that's their background. If you say the left joint, well, there's a lot of joints down the left side. You have to be very specific and say the left TMJ. So your approach, your examination, your documentation, your clinical notes, all you have to do is tweak them. They will still be acceptable to dental insurance, but they will be that much more acceptable to medical insurance, because now the physician or nurse will understand what you're talking about, where you're coming from. And the medical history of the patient, if they have a medical history also, you want to use that to your advantage and bring that into the equation. Any medications they're taking, look at all the baby boomers now. It's a huge segment of the population. And when you look at the baby boomers and the medical issues they have, with the American Medical Association reporting that 70% of Americans are overweight, and of that number, 41% are obese. So that brings in the issue of diabetes and cancer and heart disease and all of that. You have to bring that into the equation, because the medications they're on, the treatment they're receiving is going to impact their oral health, their dental health. You've got the patients that are the meth addicted patients, bulimics, anorexics. All of these issues are critical. And I find so many times the history taking that the dentist does is not addressing a lot of these issues. And that becomes critically important to the success of medical billing in the office.
That is amazing. Not to get political, but I have to ask, since your brother is a physician in Canada and you are a dentist in America and you've been doing medical insurance billing for so long, healthcare has always been a political hot button forever. I mean, and now it's it's so huge. Who do you think has the better system? Do you think Canada with a single payer, or do you think America and the free enterprise?
Absolutely not. My brother on a daily basis says to me, I wish I had been a dentist, because he said the medical system in Canada is an absolute disaster. Single payer is a disaster. That's why you see patients coming to the U.S. for their treatment. He said to me, and I found this to be absolutely unbelievable, because this was not the case when I left Canada. He said, if you need an MRI or an angiogram or a mammogram, you cannot have it done at your local hospital. Canada has set up regional health centers that do these tests, diagnostic and screening tests. And you have to, the radius, and obviously in a larger city is smaller than it is in a rural area. However, you have to make an appointment at one of these regional health centers. It takes you anywhere from 12 to 15 months before you can actually get the test done. And he said the way the healthcare system saves money is that patients die before they actually get the treatment because they're not even diagnosed for 12 to 15 months. He said, if I want my patient to get an MRI or a scan ASAP, I go next door to my vet's office. He has the machines. I have the patient scanned there.
My doctor told me if I gain 10 more pounds, he's going to have me get a mammogram. And I think one of the problems with Obamacare and all the medical deal is that, it seems like Americans don't realize that about a third of that cost is admin. And you go into almost any dental office, when they do dental billing, forget medical billing, when you do dental billing, most all your practices that are at the $1 million level say, you know what, I got to talk to a human. They have to call someone at the insurance company and be on hold. They have a full-time employee at the front desk in a room getting somebody on the line because why isn't that just automated? Why do you have to have your number one expense, labor, talking to their number one expense, labor? And that's where I think Obamacare failed the most. They did a lot of noble stuff, like got rid of pre-existing conditions and let you keep your kids on your insurance plan, but they did nothing to address the unnecessary cost of admin. And man, just a few changes in admin, they could have cut the admin costs in half with hardly even trying. Why is that not so obvious to government?
Well, first of all, let me address the issue of pre-certification, pre-authorization with medical, okay? For CT scans, when you pre-certify a CT scan, you get transferred to an RN immediately, and you get an authorization within 2 minutes, okay? If you're doing surgery, which requires a pre-certification, elective surgery requires pre-certification, you are able to do it online. You get a response between 24 and 72 hours later, max, 24 to 72 hours. Not like dental insurance where it's 6 to 8 weeks to wait for a response, okay? The other issue with the medical is the single payer system, very inefficient. You look at Medicare, horrible. A lot of fraud because Medicare does not require any documentation. And there's a lot of fraud in the system. With the traditional insurance, the commercial plans, you have documentation that you have to submit in order to be paid. And that obviously has to go through medical review. So there is that hang up. However, like I said, 24 to 72 hours later, when I see checks $25,000, $30,000, $50,000, $90,000 coming from medical insurance, that time frame for processing that claim and getting that check is from 4 to 6 weeks. We're talking big checks. With dental insurance, you're talking these pathetic little benefits of under $1,000, and it takes that long.
So right now, what percent of dentists, general dentists, do you think bill medical? What percent right now?
A very low percentage, only because they are not familiar with how it works, or they've tried it on their own because they think it's just like dental billing, and it's nothing like dental billing. So they submit a few claims, they get rejected because they approached it like they approached dental insurance. They get rejected, they get a denial, and they say medical billing doesn't work. Well, it works, but you have to understand how the process works, and you have to understand how to approach with the documentation. You don't submit radiographs, you don't submit periodontal charting, none of that. You submit your claim with medical codes, with a letter of medical necessity, and that's not a letter from the physician. It is a letter from the treating dentist that explains in medical terms what needs to be done and the mindset and the thought process behind it. And then you also submit the head and neck evaluation of the patient. It's a comprehensive head and neck evaluation, and I actually have it on my CD, where all you do is you follow the check boxes, check, add in the general medical history, add it to the patient's health record, or print it out, and off it goes to the insurance company.
Well, tell your brother I'm going to move to Canada, so I'd like to meet him. I figured out if I just moved from Canada, my weight in pounds would be cut in half in kilograms.
Yes, it will.
And that's how they should solve global warming, is just stop measuring it in Fahrenheit and measure it in Celsius. We're all there. We're right on track. So what could so we both agree almost nobody does this. But if they start doing this, like what percent of revenue could it be? I mean, is this something where when dental offices get involved in this, it's now 3% of revenue, 5%, 10%? What could this be?
The offices over the years have told me that it has increased their bottom line by anywhere from 30 to 50%. I didn't think it would be that much. I thought it would be more like 25 to 30%, but the offices that are doing it, that are proficient at it, that have put in the time to learn how to do the process correctly, are telling me that's what it's. I just got an office yesterday, a prosthodontic office, that told me they're already 32% ahead of last year in their gross earnings because of medical billing. When the recession hit in 2008, the offices that were doing medical billing, these are general dental offices, were telling me that they could not fill their schedule fast enough, that they were booked out 6 to 8 weeks, and offices around them said, we're at 50%. We're scared that our practice is going to go under. How are you doing it? And they said it was because of the medical billing. Two things. Patients were either afraid of losing their benefits because they were losing their job, or they were using the medical benefits that they had in order to pay for treatment that they needed, that they didn't even realize medical covered. Patients talk to other patients. That's your best. You don't even have to do any marketing. Patients talk to other patients. They talk to colleagues. They talk to people at work. You know, people have told me that their patients will be sitting at having a cigarette outside, or having lunch with a colleague or a coworker, and they'll say, you know, isn't this great? Our insurance is so good. I just had 2 implants placed and our insurance covered it. And their coworker will say, wait a minute, I just went to my dentist for implants, and my dentist said it was going to be this much, and it's all out of pocket. How on earth? What's your dentist's name? Let me go to your dentist.
So you've taught at 3 dental schools. What's
Yes.
that like? Did you do that for the money, for fun, because you love
I
teaching?
love teaching.
What are your thoughts on the current state of dental schools?
I think that the dental schools, first of all, you know, so much of the curriculum now is very similar to what you and I went through. Um, and so 4 years is not enough. It's no longer enough, and you need that extra year. And that's why either extend dental schools for 5 years or make that residency program mandatory, because there's so much to learn. There's been so many advances in dentistry. 4 years is just not enough. You know, practice management is pretty much non-existent as far as the dental school curriculum goes. And so I used to have lunch and learns with my students every Thursday, teaching them practice management in the real world. You know, they would come to me, and this was, I remember distinctly one situation in 2001 when I was teaching at Northwestern before it closed. A student came to me and said, you know, I'm going to be coming, and I'm looking for an associateship. And the practice management course that we had here told us that we should ask for a minimum of $150,000 as an associate. This is in 2001. And I said, you got to be kidding. Who's telling you that? Well, Dr. So-and-so was teaching practice management. I said, look, nobody is going to hire you. You have no experience. You're slow. You don't have the knowledge, the background, that you're not up to speed yet. There is no way you're going to get 150,000. You'll be lucky if you get 75 to 90,000, but you have to prove yourself. You have to start at the bottom, work your way up.
I want to ask you a question. I hope it's not sensitive or anything, but you graduated from the University of Toronto in '78, so you're coming up on 40 years of practicing. Would you say when you graduated from dental school, dentistry was a man's profession, and now that's changed to a woman? Did you feel like an outsider in a man's profession in 1978, or was it really gender equal back then?
You know what? My year, out of 135 students, there were 19 women. The year before me was 12. The year before that was 6, and the year before that was 2. One of the things that I found is that we were expected to be as good, if not better, than the guys. They basically watched us all the time, our fellow students. Were we using our feminine wiles to get ahead and all of that thing? So the expectations were higher. I never felt I was treated differently by the staff. I never felt I was discriminated against. Never in my career have I felt that. I think a lot of it has to do with how you conduct yourself. The respect that you command is the respect that you get from people. And if you conduct yourself appropriately, professionally, etc., that's how you're going to be treated by patients, by colleagues, etc. I've never felt unequal. I've never felt a problem. I've never felt my pay is any different, my income. Never.
Nice. Any advice? That you've been in 3 dental schools. You've seen this rodeo for a while. We just had 6,500 kids graduate from dental school in the last 2 weeks. They just left. You've taught at 3 dental schools. What advice would you give to all these kids who just walked out of dental school? And I'll give you a heads up. Do you think they're coming out of school humble and hungry, or do you think they're coming out of school, they know it all, they learned it all, they got their diploma, and they're ready to go?
I'm seeing a lot of them have this entitlement issue that I've got the diploma, I deserve a huge salary. That's not going to happen. That's not going to happen. I think that the one piece of advice I would have to them is take as much continuing education as possible. Number one, really be careful about the continuing education that you select, because all continuing education is not equal. And I would say in my estimation, about 30% of the continuing education is something that I would say is of great value. The other 70% tends to be fluff and self-promotion and that kind of thing. So ask the seasoned dentist that you trust, that you respect, in practice, what they would recommend.
Yeah, I think when you come out of dental school with $350,000 in debt, I mean, I can't believe how many dentists, even 10 years out, they'll call me up and they'll be talking to me about advice, or I'll be lecturing, I'll have lunch with them, and they're having all these financial problems. Say they're going through a divorce and they're putting 2 kids through college and all this stuff, and then you go to their hours, and they work Monday through Thursday, 9 to 5. I'm like, dude, you're going through a crisis and you're on 3-day weekends. They have that Monday through Thursday, 9 to 5. I never did 9 to 5. I did 95 hours a week. That was my 9 to 5. I mean, my God, I did, my office hours the first decade with me was 7 to 7 Monday through Saturday. And you could just work through, I mean, you got massive experience. I mean, the best way to get good at endo and crown and bridge and fillings is do 1,000 more of each one of them.
Yeah,
I mean, when you do 1,000 more fillings, you start figuring out how to do a damn filling. 9 to 5 should be 95.
Yeah, I mean, my first few years were 8 to 6 days a week. You got to put in the sweat equity, without a doubt. You have to put in the sweat equity to get the rewards, and you learn the most from your mistakes. And I think the best lectures I've ever been to, also as far as CE goes, were when the dentist showed all the mistakes they made and then how they handled them. Because all of us have perfect crown preps that we've done, perfect situations that we've treated, perfect fillings that we've done, but we've learned the most from when things go wrong and we screw up. That's when we learn.
And here's when someone's old school. So old school, which is funny, the people with all the money, they buy textbooks. They're like $250, and that's what you said. The scripts, avoiding complications in oral implantology. Here's 800 pages of dental implant screw ups. But the millennials, they won't buy a 280 textbook. They'll buy a $280 airplane flight one way to some course on the other side of the country, drop $3,000, come back, and they'll have like 3 pages of notes.
It's all in your priorities, without a doubt. God bless Carl Misch, because he was an outside the box thinker, and he left his imprint on dentistry. Unbelievable,
And would you
unbelievable.
say he worked 9 to 5 Monday through Thursday?
Never, never.
Oh
No,
my God! And not only would
no.
not only would he work like 7 to 7 Monday through Friday, but then Friday after work he'd fly
He'd
to
be
Rome
lecturing.
and lecture in Rome, then London, and I mean, you know how many times that guy landed at the airport at 6 a.m. and had a full schedule of patients at 7?
I know it. I know it. He was one of a kind, no doubt about it.
God,
But
he was an intense dude, and I think he was totally down to earth. I mean,
he was.
he'd sit at the bar with any dentist from anywhere and talk till 3 in the morning about anything dental implant related. He was so approachable. You go to so many of these lectures a day, and as soon as the lecture's over, they just like disappeared. It's like they went out some back hidden door, and you're standing like, where the hell did he go? Carl would get done lecturing at 5, and he'd stand in the room holding court till 8 p.m., then go to the bar and hold court till 1 in the morning.
Yeah. I mean, that man, obviously dentistry implants were his passion, and you can always tell the difference between somebody to whom dentistry is a, or for whom dentistry is a job versus somebody for whom dentistry is a passion.
Yeah, I call it when I was little, it was a Catholic family. I went to mass every day, and they always called it, are you going to go into an occupation or a vocation? And when you go into a vocation and you got passion and purpose into it, you seem to be, if you're purpose driven in a vocation, I mean, like Carl Misch, implants was his entire life. It was his passion. It was a vocation. It wasn't some 9 to 5 job he did so that he could go home and watch ESPN. It was so yeah. So on that note, how would you help these little kids who just come out of school find their passion? How does she find her dental passion? And I want to tell you why I'm asking this, because the one thing that scares me is half of them. I mean, what are the endo requirements in dental school? 3 teeth, and half the class comes out and says, "I hate endo. I don't want to do endo." 80% of the boys, what was your pulpotomy requirements? I did one, and I hate it. I never want to treat a kid again. So they're walking out of school. They already hate endo. And then another thing with these millennials, half of them tell you they don't like, they're not apical barbarians. They don't like blood and guts. They don't want to pull teeth, gum surgery, implants. They just want this white, fluffy stuff, bleaching, bonding, veneers, sleep apnea, and Invisalign. It's
How do
like,
you?
dude, are you a doctor?
Yeah.
I'm pretty sure that, and then they say they don't like blood. I'm like, then why aren't you graduating with a degree in electrical engineering? I mean, how the hell did you go to dental school and didn't know humans were filled with blood and guts? Are
Well,
you a
it's
blood and guts apical barbarian, or are you a white, soft, pretty, fluffy, bleaching, bonding, veneer, sleep apnea, Invisalign girl?
You just reminded me of an assistant that I hired when I was working at one of the hospitals, and she worked with me for a day, and then the second day she didn't show up to work. So we thought, oh my God, something happened to her. So we're calling her. Finally, we reach her, and she says, "Well, I quit. I didn't realize it required so much suctioning." I said, "What? You're a dental assistant. That's part of your job. What do you mean?" She's like, "No, I didn't realize that I'm not cut out for suctioning." So it's,
Well, you should have just bought her an isolite, because I think an isolite's better than a dental assistant. I mean, it retracts the tongue, the cheek. It does better suctioning, but more importantly, when you're old, 54 years old, and can't see, it floods the area with light. And then while you're doing that with better suction, better light, Jan is entering the notes,
right.
setting up the next room, all that stuff. But back to the passion. I'm afraid of this girl because she's already made up her mind. She just graduated with $350,000 in debt, and she's already decided she hates endo. She doesn't like blood. She's not going to pull a tooth. I just think she's so young, she might not know that when she's as old as us, that might have been her total passion in life. So how does she find her passion?
I think what mentoring is critical. I think mentoring is underrated in dentistry, and it's the kind of thing that's the other thing I would add to the dental curriculum is to have shadowing programs, if you will, with dentists. And I know several dentists that actually do shadowing programs, but somebody doesn't know what is exactly involved in dentistry when they've only done one or two procedures. They don't know. And the reason they may have gone into dentistry, they said, oh, dentists live in nice houses, they drive nice cars, they may dress well, whatever it is. They see the external part. They don't see the day-to-day grind, what's involved, the things that float our boat, and why we're actually happy in our profession. And my profession, my personal career has taken a lot of turns here and there. I've done hospital dentistry, I've been in private practice, I've been in group practice where there were 17 of us, general dentists, all the specialists, physicians as well. And it was an outstanding relationship as far as interaction and all of that goes. But I think mentorship is critical. And finding a good mentor, spending a lot of time with that person and learning about what floats their boat, I think is very, very important. Doing it on your own, it's like you're a boat out to sea with no destination. You have no direction. You really don't know what you don't know. And until you find out what your goals are and set your goals, you're going to be floating, and you're going to be very unhappy with your choice of career. We do a lot of e-blasts as well, and we get a lot of response from that. Most of the time, what I find as far as the courses and all of that, it's word of mouth, because a lot of people have now jumped on the medical billing bandwagon. And again, this is where I caution people. There's courses and there's courses. You want to make sure that you learn from somebody who has been there, done that, on both sides of the coin, both internally processing in insurance companies, so they know how insurance companies operate, their mindset, and have their connections within the insurance industry, as well as on the outside practicing and clinical practice, not just teaching it, because, like they say, those who can do it, those who can't teach, huh? Especially if they're doing it full time. So I think it's important to select your course, whether it's in clinical dentistry or in practice management. Select the right course and make sure that you put the time in to learn it. Because medical billing, there is a learning curve of about 4 to 6 months. I'm not going to lie about it, to get things running smoothly and being paid on a regular basis and seeing those $3, $5, $10, $20,000 and more checks coming in. It's well worth it. Well worth it. You think of the time that you spend in dental billing and providing all those narratives and this and that and the other, and then you get a check for $350 after jumping through all those hoops. Is it worth it? Heck no. And you look at, I tell patients, drop your dental insurance, get better medical insurance. It's so much more worth it because of the procedures that are covered under the medical plans.
This is so fun. I'm actually, because I'm podcasting you, we need to add a medical billing category.
I think it's even more critical, Howard, than dental insurance, because you look at, dental insurance. Okay, when you started practicing, what were the calendar year maximums? $1,000, $1,200, $1,500. They're still the same. It's ridiculous, absolutely ridiculous. You look at the benefits of medical insurance, there are no calendar year maximums. There are no procedure limitations. If you need to do 5, 10 exams a year, they're all going to be equally covered. There are no lifetime maximums. So for those 3 reasons alone, medical billing is essential to any dental practice. People say, what about high deductibles? Okay. Only Obamacare plans do you have to come up with a deductible upfront in full. Now, that's been the other downside of the Affordable Care Act, is 80% of the people who are on the Affordable Care Act have their premiums subsidized by you and I, the taxpayers. Okay. When you look at the deductibles that they have to satisfy before their benefits kick in, they have to come up with that money. For a single per individual, that's around $3,000. For a family of 4, it is around $10,000. Now, if these patients can't afford the premiums, how on earth are they going to pay the deductible up front? The deductibles are not subsidized by taxpayers. And that has been the other failure of the Obamacare system. Hospitals are now requiring Obamacare individuals with those policies to pay up front before they will treat them for elective procedures. If it's a non-emergency procedure, you have to pay your deductible upfront. Physicians as well. And so you find physicians are not taking Obamacare patients because they know they're not going to be paid until that patient satisfies their deductible. The insurance is basically useless. Now, with commercial insurance, non-Obamacare insurance, that's not the situation. The deductible is eaten away gradually. So each claim that you submit, a portion of it goes to the deductible, then there's the copay, and then the physician gets reimbursed as well.
You know, when we say we're physicians of the mouth, I mean, we're really not. I mean, when people say, well, a dentist, you know, your brother's a physician. When people say to you, well, you're not a real doctor, you're a dentist, you know, you're not a physician. I almost think it's true because, like, look at dental insurance. Imagine all the oral cancer technologies that were available in dentistry really came from female cancers downstairs, you know, swishing the toluene blue, looking at that Bell scope, all that technology, and health insurance paid for that. I mean, Delta, and the biggest dental insurance doesn't pay for an oral cancer screen. Imagine the uproar if the Medicaid and Medicare quit covering female cancer screenings. Mm-hmm. It would be outlandish, but no one covers it in dentistry today. Another thing that's outlandish is...
right, it's not covered under the dental insurance, it's covered under the medical.
Yeah, and the other thing outlandish is dentists, I mean, our biggest nightmare problem that we have isn't a cavity or gum disease or occlusal disease, it's oral cancer. And now it's, you know, it's exploding from HPV, yet dentists aren't even allowed to give an HPV shot. Dentists aren't even fighting for the chance to get an HPV shot. And look at the influenza. I still can't believe 8,000 to 38,000 Americans die each year from the flu, and they're always elderly grandmas. And when they go back and say, where was the last entry point into the U.S. healthcare system, the dentists are always in the top 3. And that hygienist got a 4-year degree, and she's looking for gingivitis. Why doesn't she give a flu shot in the arm? And it's now only legal in Tennessee. I mean,
that dentists have been pushing for cosmetic things, you know, the Botox, the this, that, and the other with the cosmetics rather than the medical issues. And I would disagree with you about the physician in the mouth thing, and maybe it has to do with my training. My first 2 years in Canada in training were identical to my brother's. We both went through our schooling at the same time. And in addition to that, my training also involved, you know, learning oral pathology and all that stuff. In addition, we were taught in the medical school by the same professors that were teaching the medical school students. The other thing, when we graduated, my brother was always testing me, always. And when we graduated, he said, I have to hand it to you. Dentists know more about the body than physicians know about the mouth. And I found that in my training, not just in dental school, but also in my residency training.
Nice.
It's absolutely true.
Yeah, I agree. You can find individuals going for it, but the fact that there are 211,000 Americans alive right now with an active license to practice dentistry, 150,000 would be general dentists, 30 hours a week or more, 30,000 would be specialists, 30 hours a week or more. But the fact that none of them are given flu shots, none of them are given HPV shots, none of them are getting reimbursed from dental insurance for oral cancer screenings. And I mean, you're talking a lot of oral cancer deaths a year, and all this stuff like that. And then when I hear the nitty gritty details that when a board voted on whether or not dentists and hygienists can get flu shots, it was the damn dentist on the board voting it down. It's like, are you out of your mind? I mean, it would have made sense if Walgreens voted it down because they want you to go to them to get a flu shot, or maybe your family physician. But it's like the dentists are their own worst enemies.
They are, absolutely. And I find organized dentistry, when they complain about, you know, membership declining, especially with the millennials and all of that, hello, you know, let's look at what you're doing for us, what you're doing for the profession. You're more worried about being in bed with the insurance companies and not offending the dental insurance companies than you are being on the side of the dentist and fighting for flu shots, HPV shots, all of that. Why aren't you fighting for that?
Here's another weird thing about the dentist, especially in the South. they won't even talk about HPV and sex and oral sex. They're like, that is not an appropriate discussion. I'm like, well, if you can't have that discussion with your patient, then where do they go when they need a doctor?
Absolutely.
I mean, are they going to go to their minister? I mean, what do you think it states of the profession when many parts of the country they can't even mention HPV, sex, oral sex, and you're working on a mammal that reproduces and has offspring and gives birth to live young and nurses them?
It's ridiculous. And when I was teaching at the University of Illinois, a student came to me and he said, I see this lesion on the palate, and it's a 16-year-old boy, and I don't know what it is. Can you come take a look at it? And my first question to him was, describe the lesion. He says it's red and it's circular. I said, did you ask the kid whether he's had oral sex? He said, oh, I can't do that. I said, you're a doctor. You can do it. He said, I can't do it. He says, are you going to do it? I said, watch me. He trailed behind me as we walked in. I looked at the kid and I said, have you been having oral sex? He said, oh my God, don't tell my mama. This was a male. He was having oral sex with another male. Okay. And he says, just don't tell my mama. Don't tell my mama. I said, it's critical for me to know because of what we're seeing on the roof of your mouth, in the back of your mouth. And that's exactly what it was. It was from oral sex, a circular red lesion, just like, the old school hickeys and all of that nobody even knows what they are anymore. But that's exactly what it looked like on a soft palate. And that's what it was. And I said, without addressing those kind of issues, without asking questions about their patients, about their history, their sexual history, their drug use, etc., whether a child is 8 years old or a grandma is 98 years old, I am surprised when I ask that question. And again, it's how you ask the question. But I'm surprised at how many of them are toking up. And when I say how you ask the question, too many times I find dentists also are turning red, looking down at their shoes when they're asking the question. Well, the answer is not on the tip of your shoe. Ask the questions, be professional. You're a healthcare provider, you're a healthcare professional. Conduct yourself accordingly. Let the patient know why you're asking the questions and why it's critical that you have an honest answer.
And it's part of our culture. I mean, you have a movie where Rocky or The Rock or the governor of Schwarzenegger has 100 people shot with an AK-47, and it's a PG-13 family movie. But if a mammal shows a mammary gland, they all run for the doors and rated R, and it's a very bizarre culture that you're a doctor and you can't talk about bodily functions of eating and drinking and reproducing, having offspring. And now the end result of that is patients are dying of oral cancer who had their teeth cleaned every 6 months, and no one mentioned the HPV vaccine. No one told her that. A lot of people think that if you wear a condom, you just need that for sex, but you don't need that for oral sex because you can't get pregnant. And nobody's having that conversation. So the result is you have to die because the biggest joke remember, I went to Creighton, it was a Catholic college. The sex talk from your parents. Yeah, there wasn't one kid at Creighton that got the sexual education talk from their parents. And those are the same parents who don't want it taught in school because they thought it should be taught at home. But not one of my Catholic friends ever had a dad or mom sit down and explain the birds and the bees. It's a very crazy deal, but it needs to be changed because I think
a lot of it has to do with how it's addressed in dental schools and those who are teaching it to the students coming through the program. And if they're uncomfortable with it, if they're turning red and hemming and hawing and embarrassed about it, well, that's the impression that the student gets. That's the impression the patient gets, that it's somehow taboo to talk about it. And it's not. You're a healthcare provider. Conduct yourself accordingly.
And the best line of this deal was the dentists know more about the body than the physicians know about the mouth, because every year when I get a physical, I almost can't quit laughing when he gets to my mouth and he says, open wide. He puts in a popsicle stick, says, say aw. And he's got his lights. I say aw, and then he throws the stick away every year. And I think, okay, I've been a dentist for 30 years. What the hell could you have done pushing down my tongue with a popsicle stick and shining a light in there? What was he looking for? Like a sign sitting on my tongue? a message. I mean, talk about the lamest exam in the world. Could you imagine doing a 6-month recall exam and walking up to you, hey, Dr. Zook, I'm going to need you to open your mouth, say, aw, shine my light. Okay, all good.
That's it. We're all good. It's funny because I lectured to, when I was an attending at the hospital, I would lecture to the physician groups and I would show, slides of different pathology and just simple situations in the mouth. And so many physicians would say to me, what's that silver thing around the tooth? And I said, that's a denture clasp. They're like, we've never seen one. And I'm like, yeah, you have. You just are not paying attention. You're working with blinders on, looking into the throat, the pharynx, whatever. Everything else around it could be falling apart. You could be having oral cancer. You could have aphthous ulcers, whatever. But you're not focusing on that.
And I just want to say one last thing. You promised me an hour of your precious life, and we're already 10 minutes over because I keep babbling and won't shut up. But when you're young and out of school, you got to run for mayor. And the best marketing, you said it earlier that you need to find mentors. And when I was a young dentist out there, I asked every pharmacist to go out to dinner with him or bring him to my house, the physicians, the pediatricians. And just because 80% of each segment might have said no, the 20% that did say yes, those are your extroverts, those are the talkers. And if you're going back to some town of 20,000, you should ask every single physician and dentist and chiropractor and everybody out for dinner. You'll learn the oral systemic link. You'll meet friends, and the referrals are crazy. Every pediatric dentist.
Your network building is critical, absolutely critical, and you have to put in the time. It involves a lot of schmoozing, a lot of, going out for dinners and all of that, but it pays back in spades.
And your net worth is equal to the size of your network. And I never went to dinner with a physician or a pharmacist or a chiropractor and didn't learn something. I mean, I thought it was very fun. But my gosh, it is amazing how when you press the flesh and run for mayor in the 17% of the U.S. economy healthcare sector in your own zip code, your own town. And my God, if I've got 2 of everything in my iPhone, cardiologists, internists, chiropractors, pharmacists, all friends. Mm-hmm. And that just gets so many word of mouth referrals. I mean, so get out there and run for mayor. The best way to learn about the oral systemic link is go to dinner with everybody who treats any part of the body, and no matter what way they do it. You know what I mean?
Absolutely. And I think the other thing that I would say, and what I found really valuable, is whenever I came up with a treatment plan, I would discuss it with my colleagues and said, how would you do it? How would you do it? And just getting different perspectives, especially on the comprehensive cases, really opens up your eyes and your thought process as to the possibilities that you may not have thought of.
Can I just ask you one last overtime question, then I swear I'll shut up? There's kind of a lot of bias and negativity towards anything alternative. Whenever you're with dentists and anyone says the word alternative or holistic, immediately the quack watch goes up, the aluminum tinfoil hat, all the kind of thing like that. But as a businessman, when you're in the market, a huge portion of Americans don't want to take a bunch of pharmacy pills and don't want to take a pill for every problem. And they're always trying to solve things naturally or alternative. And dentists, it's funny because when a dentist has high blood pressure, he doesn't say, oh, that was great. It worked out great. I got a pill. I take a pill every day. No, they decide they need to lose weight or quit eating bacon or something. So the dentists all act alternative and all natural and all holistic. But man, is it a racist, bad, toxic word. What would you say to the young millennials who are going to come out and all the older dentists, you say those words and you're a whack job? But what percent of the people in Chicago would rather try to treat something natural and holistically than just go to the pharmacy and get a pill?
I think people are a lot more open-minded these days, whether it's chiropractic, yoga, Pilates, vitamins, minerals, whatever, alternative oriental medicine. I think people are a lot more open-minded about it because traditional medicine, yes, it's important, but there's a lot of value in the alternative options as well.
Well, it's a big marketing words. I know some dentists who just said all natural and we practice off the grid. We don't leave a carbon footprint. Our entire office is run by solar. And they have people driving gasoline engine cars an hour across town to go to
Or
the dentist that's
or like the
powered on solar.
yeah, celebrities in their private planes, but they're all about the environment,
Yeah,
yeah,
yeah, I know. They fly their Citation 5
right.
telling us to walk to work.
Yeah, do
Yeah.
as I say, not as I do. And it's like the physician who smokes or is overweight and says, you have to lose weight and you have to quit smoking. Okay. I mean, yeah, let's consider the source.
I'm pretty holistic. I mean, when I get sick, I'm 100% Irish, so I'll just go eat a bowl of Lucky Charms with milk, or and chase it down with some Jameson whiskey, and it works every time.
Because
So
it sterilizes you inside. See, it's the alcohol. It works.
Hey, seriously, thank you so much today for coming to my show. I think you're just wonderful. You were so informative. In fact, you're such a unicorn that I had to, on Dental Town, I can't believe it. I was going to look at what questions were under medical insurance billing. It's like, Jiminy Christmas. We have 50 categories. One of them is insurance. And under insurance, we have claims processing, coding Q&A, Delta Dental, dental insurance for dentists, disability insurance, dental liability insurance, PBOs and HMOs, life insurance, malpractice, Medicaid and Medica, and welfare. It's like we didn't even have medical insurance billing.
We don't have it. I know. I've been checking, and I said, "What the heck?"
So I'm going to tell everybody from now on that I actually met the Tooth Fairy, and she was riding a unicorn in Chicago, and her name was Dr. Z.
That's it.
Thank you so much for coming on the show today.
Absolutely. It's my pleasure. We'll talk to you soon.